Afternoon, evening. Hello, everybody. Thanks for joining. This is the APSA SVS Joint Task Force webinar that we were doing quarterly. And today we're going to be covering arterial thrombosis in children. Mary, are you able to share your slides?
Yes.
Okay, great. My name is David Rothstein. I'm a pediatric surgeon at Seattle Children's. And I'm going to make some introductions and kind of lead the beginning, and then Regan Williams, who is my co-lead from APSA and a pediatric surgeon at Memphis, will help take it from there. Next slide. Just as a reminder, I think many of you are sort of familiar or getting familiar with this SVS APSA Pediatric Vascular Initiative. Maybe next slide, please. This was formed probably 2 years ago now as a joint venture between our respective societies to try to improve collaboration and research and patient care in the sphere of vascular surgery in pediatric patients. Next slide. Today we're focusing on arterial thrombosis. We do a quarterly webinar, one each at our respective society annual meetings, and then one on off times. Today's panelists include Regan Williams and myself, and then our guest speakers are Erica Mitchell, who is a vascular surgeon at the University of Tennessee Health and Science Center, a professor-in-chief there. And then my colleague at Seattle Children's, Gavin Roach, who is a hematologist particularly interested in thrombosis and an associate professor at the University of Washington. Next slide, I want to just highlight some of our other people on the task force. Our co-leads from SVS are Drs. Don Coleman and John White. Most of you in adult vascular surgery, of course, know these two. And you can see here listed our task force members, which are blended from the pediatric and adult vascular worlds. And they've been great allies in our journey. And as well, without Mary Bodach, who is our face here, and Riva Bouchan's support from SVS, we wouldn't be able to do most of what we do, certainly logistically. Next slide. I wanted to offer these four, you can pass through these four, I don't know if they're questions or statements or frameworks that I think we can apply to a lot of what we do in this combined pediatric and adult world, highlighting collaboration between our services. Specifically for this talk or this webinar, when does an arterial thrombosis, is that mostly it's provoked, but when should we be thinking about a bigger picture? And we'll ask Dr. Roach particularly to comment on that. Anticoagulation might be very standardized in the adult world. I suspect it's not completely standardized, but when, what agents, for how long, how do we measure them, and which indications are there? And then very importantly, follow-up. It's important for all of us, but particularly in pediatric surgery, we think about long-term outcomes and what can be specific to vascular surgery. Why don't we start with our first case, and we'll ask, honestly, anybody can answer. Dr. Mitchell is our sort of panel expert, but there's a lot of people who take care of kids on the panel, both from our world in pediatric surgery and the adult vascular world. This is a pretty common scenario, a 4-month-old who's undergoing a diagnostic cardiac catheterization through a femoral arterial approach. They use a 4 French sheath, they heparinize it. Case is sort of average duration. And then 60 minutes after the case, a nurse calls you to the recovery room to see with concern about limb fullness and pallor. And then next slide. And then when you see the patient, indeed, the ipsilateral foot is cooler and paler than the other one, and you have some faint pulses. And I guess my first question for anybody would be, would anybody not image this patient? And maybe Dr. Mitchell, I may ask you to start with this discussion, but anybody wants to either put up a hand or chat, we'll try to keep up with people's comments.
Thank you very much. We get called typically for patients like this, and oftentimes they're still in the cath lab, and the cardiologist, the interventional cardiologist, will give us a call. And of course, we come over immediately and assess the patient. And the first thing that we will do is pull out our handy dandy Doppler. And then after we evaluate them with Doppler, then we oftentimes will just do our own ultrasound, since ultrasound is usually available in the cath lab, and just look to see whether we see the artery or not, and whether there's thrombus in that area, And of course, we always get a formal study as well, just for formal documentation. In a setting like this, we typically, the first thing we do is ask whether they're safe to be anticoagulated. And if that is the case, that is usually our standard regime, is to anticoagulate these patients and observe them and really just kind of give a wait and see approach. And
is there a role for anticoagulation in the absence of demonstrable thrombus, whether it's occlusive or not?
If we see thrombus within the artery, we will recommend it. And obviously, if we don't get any Doppler signals or ultrasound shows no flow in a zone of the artery, we will. But of course, we don't really know for how long. Oftentimes we'll watch these kids for a week, and things will improve with time. But I know there's really no hard and fast data on that, but that's generally the way that we manage these patients. And I look at other colleagues.
So I'm hearing from you that regardless of findings, but let's say regardless of whether there's occlusive or non-occlusive thrombus, you would still initially treat the same way. Is that correct?
Our feeling is that if there's an intimal injury that's very thrombogenic, if you remember Virchow's triad, low flow, intimal injury, hypercoagulable state, in that setting, we will anticoagulate.
Okay. Anybody on the call would treat differently based on the Doppler findings? Okay, so as Dr. Mitchell pointed out, next slide, please. That there are not great. I think we can keep going. One more. There aren't great guidelines. This is This is a 2012 publication from CHEST, and it's mostly aimed at venous thrombosis. There have been a couple of updates. Gavin, can you, Dr. Roach, rather, can you maybe comment on what does anticoagulation mean, and what goes through your mind in this patient about what you might recommend in concert with vascular surgery's recommendation for anticoagulation?
Yeah, absolutely. Thanks very much. So I'm a little nervous here to be talking to a room full of surgeons. I think this might be my first time, but really happy to be here. So thanks for inviting me. So yeah, in hematology, of course, anticoagulation is like the bread and butter of everything we do when it comes to treating clots. And as you already mentioned, in the case of venous clots, we have probably a lot more data compared to arterial clots. So for a case like this, our approach is very similar to what Dr. Mitchell just described, which is that we would assess the patient and order an ultrasound and likely anticoagulate immediately in the case of thrombosis. And I would say, I think perhaps there's a role for starting anticoagulation with strong clinical suspicion, even in the absence of having an ultrasound readily available. If, for example, you didn't have a bedside Doppler available, but the limb was clearly pale and cool to touch, it would not be inappropriate to start anticoagulation while you're waiting for a study to be done. And I think there are some centers who do that. It's relatively common to develop an arterial femoral clot after cardiac catheterization. I think there are some studies that say up to 10% of pediatric patients are at risk for this. And so we've actually developed an institutional guideline at Seattle Children's, sort of like a quick reference for those people on our staff who take care of these patients after cardiac catheterization. And it just sort of lays out, order the ultrasound, start the anticoagulation, check the patient frequently for pulses, those sorts of things. And when we think about anticoagulation, that's a broad term we use to describe what we would call like the real blood thinners or the systemic anticoagulants, which would be heparin and low molecular weight heparin products, direct thrombin inhibitors, warfarin, direct oral anticoagulants, et cetera. And I use that to contrast that with antiplatelet agents, which are sort of a separate category of antithrombotic medicines. And so for us, yes, I agree with what Dr. Mitchell said. We would start something like heparin or low molecular weight heparin. We would monitor the patient closely. And that would probably be regardless of whether it was occlusive or non-occlusive. because when you catch these things early, there's a good chance they will respond to systemic anticoagulation. And so even the occlusive ones, you might not see the infant progress to symptoms of actual ischemia that would then require additional interventions.
Great, thank you. So typically in this, remember this is like a 4-month-old, 5-kilo baby. I think typically there's such rich collateralization that even an occlusive thrombus doesn't progress to ischemia. But let's change it up. Next slide, please. Let's change it and push Dr. Mitchell. What if this foot is frankly ischemic? There's no Doppler signal. There's occlusive thrombus, maybe even extending beyond the catheterization site. What's going to push you to operate, and what approach would you take?
Yeah, it really comes down to size of the patient. I mean, if the patient is too small, and that I'm not, every patient's a little different, then we generally recommend anticoagulation and just conservative management, just following them along. And agree with you there that collateralization is very rich.
Has anybody in the call had experience in exploring the femoral arteries in an infant rather?
David, it's John White.
Yeah,
yes,
hi,
I do, unfortunately. And it's very challenging. We really don't have much instrumentation available. And in a 4-month-old, the common femoral artery is going to be somewhere around 2.5 millimeters in diameter. A 2 French Fogarty catheter, which is the smallest thrombectomy catheter available, with the balloon inflated, is 4 millimeters. So you run the risk of really injuring a vessel with a Fogarty catheter. So I would agree with Dr. Mitchell. We would, given the data that we have right now, we would continue to anticoagulate and monitor, and would defer any surgical intervention until there was a suggestion of paresis or paralysis that would push us to the operating room.
Yeah, tough cases.
But David, you're suggesting that there's a frankly ischemic foot, which one would assume then progresses to have truly neurologic deficits where you've got tissue infarction potentially and or severe motor deficits. And so I think that's what you're trying to push is at what point do you consider that anticoagulation has failed, acknowledging that surgical instrumentation is really challenging. You theoretically can milk clot back, you can use angiocaths to flush, but I totally agree with everybody's sentiment. Nobody wants to do that, and the outcomes are very poor because you're also going to have a significant amount of distal vasospasm that impedes really the effectiveness of any intervention. But is there a role for something less than a cut down and exploration? And where does lysis come into play for some of these really small children?
I had the unfortunate experience in fellowship of a patient with a single ventricle, so deoxygenated blood, in septic shock from something, with a femoral venous line that actually was erroneously placed into the artery, and she had TPN and ended up losing, very distal part of her leg. It was a very complicated patient, but back then I think it was a very different era in terms of placement of catheters and then follow-up. So it can happen. It's fortunately very rare. I'm sorry, I'm going to be the timekeeper, so I want to keep going. Next slide. This would be pretty rare, but I asked this to see if Dr. Roach can comment on if you had, let's say, maybe an A-line placement error that went awry or some injury to the artery that caused thrombosis. Are there anticoagulation considerations in this particular patient who's got a immature germinal matrix and a higher risk of intracranial hemorrhage? How would you handle anticoagulation in this patient if different from the previous patient?
Yeah, that's a great point. So we know that the risk for spontaneous intraventricular hemorrhage is greatest in those premature infants who are less than 32 weeks. But anybody who's 32 weeks or even close to that, it's certainly something that crosses our mind. Any type of thrombosis in a patient that's small, where we're considering systemic anticoagulation, it's usually a discussion with the NICU about what they perceive to be the bleeding risks of the patient. We usually get a baseline cranial ultrasound to exclude the presence of pre-existing intraventricular hemorrhage. And then it's really a risk versus benefit discussion, and usually includes family in decision-making about starting anticoagulation. I will say at our institution, our NICU tends to be pretty conservative about bleeding risk and often hesitates to start anticoagulation unless we feel that it's really absolutely necessary. And so a lot of times we may wait a little bit before starting. Or if we do start anticoagulation, we will monitor the patients with serial cranial ultrasounds just to make sure that we're not causing more damage by using blood thinners. But it's always sort of a tough discussion in these really, really small preemies.
And is bivalirudin any better in that risk than heparin, or are there other anticoagulation medications that are safer?
So at Seattle Children's, as you know, we use a lot of bivalirudin, but we're kind of alone in that. There's not many other hospitals in the country who use bivalirudin like we do. So heparin or low molecular weight heparin are going to be the mainstays for most other people. Heparin can be tough in babies because their natural levels of antithrombin tend to be on the lower side, and so it can be more difficult to get them therapeutic. Small babies often require supplementation of antithrombin to get therapeutic on heparin, or they require very high doses of heparin. We have a little bit better luck with low molecular weight heparin. It seems to be easier to get patients therapeutic on that more quickly when they're small, but it is not quite as reversible as heparin. So if you do need to shut it off for some reason, it's going to stick around a bit longer than just a continuous heparin drip. We like bivalirudin at our institution. For those who aren't that familiar with it, it's a direct thrombin inhibitor. It's basically like heparin. It's a continuous infusion. It's quick on, quick off. And we have an in-house assay available 24/7 to measure levels, which is one of the reasons why we use it and we like it. And it avoids heparin resistance, and it avoids the risk for heparin-induced thrombocytopenia as well.
Cool. And then lastly, go back to Dr. Mitchell. What about a 10-year-old with a cath injury? Would you have a different threshold, or can you just, let me not put words in your mouth, describe your threshold for surgical intervention for a 10-year-old with a partially occlusive or occlusive femoral artery thrombus after instrumentation?
In our experience, we have operated on these patients, especially if they're related to ECMO complications. I think every patient that's had an ECMO complication we have operated on, albeit the majority of them have been over 6 years old. So yes, in trauma, we operate on 3-year-olds, 4-year-olds.
Okay. Dr. Coleman asked in the chat, what are people's thoughts on medical leech therapy? In her experience, came up with a tiny 24-week premature infant with severe acute limb ischemia and strong contraindication to anticoagulation. Can I ask whoever is not muted to mute themselves, please? So anybody with experience with leeches?
I have no experience with leeches.
It definitely has come up with microvascular reimplants, but had not heard of it here.
Yeah, just
Dr.
calling the
Chong,
audience.
Dr. Chong, can I ask you to mute your phone, please? Thanks. Okay. This is an inflection point. We're going to shift to a little bit of a discussion from Dr. Roach. Are there any other questions or comments on the cath-induced lower extremity thrombosis?
David, I would just add that you have on the screen, what if no heparin? If the patient truly can't have any sort of anticoagulation, then any sort of surgery on that blood vessel is a bad idea. Then I would just observe those patients, try to lower platelet counts, isovolemic hemodilution, things like that. But But I think any sort of surgery, if heparin's contraindicated, is just really tends to be a disaster.
Gavin or Dr. Roach, is Bival also pork derived, or is that an alternative?
It is an alternative for patients who avoid pork products. It's an alternative to heparin and low molecular weight heparin, which are pork derived.
Yeah, no, that's really, I think it's really important. So we have a large proportion, not a large, a proportion of patients who prefer not to use pork derived stuff. Dr. Drucker from UT suggested using nitropase on preemies infants, but not done leeches. Last question on this, just in the framework, what I put it in the beginning, how do you decide on how long to continue anticoagulation? Let's just go back to this 5 kilogram, 4-month-old who had a catheterization. How would you decide on how long to anticoagulate them?
I defer typically to our hematologist, so at least a week or two. Generally, these patients are in the ICU. They're in the ICU and still have ischemic symptoms. We continue anticoagulation.
Mm-hmm.
Yeah, and I can address that on my slides.
Oh, great. Okay.
Which I think are coming up.
Yeah. You know what, Mary, if you don't mind, you can skip over, go right to Dr. Roach. There's a kind of a blank slide with Dr. Roach's name, and then Dr. Roach, you can take over after that. This is sort of redundant, sorry.
Okay, I'll skip through these. Okay.
Yeah, so now Dr. Roach, you can take it away.
All right, thanks again. So, when we think about pediatric arterial thromboembolic events specifically, most cases are going to have some sort of clear identifying provocation. So catheterization, by far and away, probably the most common thing we see. We might also see some cardioembolic phenomenon. And then, of course, you guys see a lot of trauma. We do occasionally get asked about thrombophilia testing, and our general rule of thumb with regard to looking for acquired or inherited thrombophilia is to think about it in patients who have no other explanation for what's going on. And so those patients who have a truly unprovoked arterial thrombosis. And part of the reason for this is that we really just don't have much data about thrombophilia in pediatric arterial thrombosis. The literature is much more robust when it comes to venous thrombosis. We know that things like factor V Leiden mutations and prothrombin mutations play a role in venous thrombosis, but there is much less data for arterial thrombosis. By far, the thing that we have the most evidence for is the antiphospholipid antibody syndrome. And that is a syndrome in which you produce these abnormal antibodies. They are phospholipid binding antibodies, and they can exist in the setting of systemic lupus, or they can exist just as a primary disorder. But when you have these antibodies present, it does confer a very strong risk for both venous and arterial thrombosis. This includes large vessel thrombosis, small vessel thrombosis, stroke, etc. And so that is definitely something we think about testing for with pediatric arterial thrombosis. If those antibodies are positive, then we do have concern about a very high risk of recurrence. And so those are patients who we would put on systemic anticoagulation, usually for a very long time, or possibly indefinitely, if those antibodies are persistent over time. And the gold standard for them would be warfarin as compared to other anticoagulants for long-term therapy, because we do have some data in adults that perhaps the direct oral anticoagulants are inferior to warfarin for that particular indication. When it comes to the other inherited thrombophilia traits, again, the factor V Leiden mutation, prothrombin mutation, protein C, protein S, or antithrombin deficiencies, we consider testing for these things, but their role in arterial thrombosis is not as well understood. With factor V Leiden and prothrombin mutations in heterozygous state, which is the most common thing we see, somewhere around 5% of the population with European ancestry may be positive for these genetic traits. The risk there is really pretty mild, and we don't make much of that. But in the homozygous state, it can be much more important. We also think about looking for disorders of fibrinogen. Dysfibrinogenemia in particular is associated with an increased risk of thrombosis. And then we think about a combination of risk factors. So, finding one factor V Latin mutation may not be super important. But if you diagnose that in combination with a prothrombin mutation, now the risk for this patient has gone up significantly because these things tend to multiply the risk. Next slide, please. When it comes to anticoagulation, there really is a paucity of evidence-based guidelines. You pulled up the CHEST guidelines from 2012, which just sort of touch base in the most briefest of ways on what to do for these patients. But we really don't know. We know that anticoagulation is a good way to treat clots. So generally, we start anticoagulation for almost all patients with a newly diagnosed arterial thrombosis. There may be some patients for whom, when they present with advanced signs of limb ischemia, the best thing to do is just rush them to the OR. But the general rule of thumb is going to be that it's almost never wrong to start anticoagulation. With something like a heparin drip, it's really easy to turn it on and turn it off. So even if you do decide you need to rush the patient to the operating room, it's something that'll be out of their system very quickly. At our institution, we've been working on an institutional clinical guideline that will address the care of these patients, in part because we had a couple of bad outcomes where patients presented with significant arterial thrombosis. There was a delay in getting them to some sort of definitive therapy, and the patients had progressive symptoms and ultimately had bad outcomes. And so the major focus of our clinical guideline is trying to get people to think about treating these patients very quickly, starting anticoagulation quickly, huddling with all the important subspecialists very quickly, and then coming up with a plan and making sure that we're monitoring the patient while we're waiting for a definitive intervention. The definitive interventions, of course, could be just anticoagulation alone, or doing some sort of thrombolytic procedure, an endovascular thrombectomy of some sort, or a surgical intervention. Next slide. I just pulled this as a screenshot from our algorithm, which is set to go live probably about a month from now. So this is what we have come up with as an institution. You can see I just put the Rutherford classification there at the top. This is specific to limb ischemia from arterial thrombosis, category 1, category 2A, 2B, and 3, which probably most of you are already well versed in. And so it is only the category 1 patients, the least symptomatic patients, who just sort of go straight to anticoagulation and stay on anticoagulation, and we monitor them. For anybody who's going to be a category 2A or higher, we're now going to recommend within 10 minutes having a risk-based huddle with the appropriate subspecialists, the most important of which are going to be the surgeons and the interventional radiologists, because those are the people who are going to help us make a decision about a definitive intervention. At our center, we don't have vascular surgery immediately available, so we have general surgeons who are our first touch point, and then they coordinate with vascular surgery if needed. And then depending on where the patient is, if they're in the emergency room or the ICU, et cetera, we involve the appropriate people. And then because there really are a lack of guidelines for what to do for these patients, we rely on this interdisciplinary discussion to figure out the next best steps. And so based on the size of the patient, the size of the clot, the location of the clot, all of these things are going to come into play when the interventionalists are talking to the surgeons and the hematologists to try to figure out who's going to be able to fix this problem and how quickly we need to be able to fix it. Obviously, the more symptomatic the patient is, the more urgency there is to do something definitive quickly to restore blood flow. And so you can see that for our institutional guideline, where we're saying that there's some evidence out of all the manuscripts we reviewed that says that for category 2A, catheter-directed thrombolysis may be preferred if available, and if the clot is accessible, essentially based on the patient and the clot. But for category 2B or category 3 patients, it's really a surgical intervention that is recommended by most of the literature that's out there. And then we have catheter-directed therapies and systemic thrombolysis as second line after surgery, if surgery is not an option for some reason. The most important thing, though, about all of this is, again, the huddle, this idea that what we need to do is get the right people talking to each other very quickly to try to figure out what the right thing for the patient is going to be. Next slide. When it comes to anticoagulation, this is yet another area where we don't have good data. We know that for venous thrombosis, we have to do anticoagulation for a prolonged period of time. We know that if we don't do it for, in the adult world, it's usually a minimum of 3 months. In the pediatric world, we're now doing somewhat shorter courses for some patients, perhaps down to just 6 weeks of therapy. But if we don't do it for that minimum amount of time, the patient's risk of recurrence is going to be quite significant. And that's probably due to the fact that venous blood vessels are slow flow systems. They require a certain amount of time to heal that endovascular lining. But with arteries, blood flow is faster. There's data that would say that we don't really need to anticoagulate patients for as long as with venous thrombosis. So the general rule of thumb with arteries is that you anticoagulate them until the clot goes away. The CHEST guidelines that were pulled up earlier, they do address femoral arterial thrombosis and sort of pulled this 5 to 7 days of anticoagulation out of a hat. It really is not based on much of anything. It was one of these very low evidence recommendations, but they basically said, you should anticoagulate and you should do it for a few days. You should pull the catheter if there's a catheter sitting there. Not much else beyond that. There are a lot of other papers out there just written by experts giving their opinion, or people who are doing retrospective reviews, reporting on case series, et cetera. And there are some who recommend anticoagulation for a bit longer than that. Generally speaking, I think people favor anticoagulating until you have resolution of symptoms, and then for a little bit longer after that. And if you do require some sort of interventional procedure or surgical intervention to restore blood flow, there are also some authors who recommend continuing systemic anticoagulation for 7 to 10 days after that blood flow has been restored. Again, and this is essentially in order to prevent a prompt recurrence of thrombosis. But the real answer to all of this is we don't know. We don't know the optimal duration of anticoagulation. If the clot does not go away quickly, we will extend our anticoagulation course. So this sort of 5 to 7 days is like an absolute minimum amount of time, but we tend to follow patients, like, let's just say it's a routine cardiac cath associated femoral arterial thrombosis. If it's persistent beyond 7 days, we would, in our institution, just continue anticoagulation with weekly or every other week ultrasounds. And then we usually call it quits with anticoagulation somewhere around the 6 week to 3 month mark, because after that point, anticoagulation is really not going to be effective. And if the clot is still there, it's likely to become chronic at that point. Next slide.
I think that was the end of the slides.
Yep.
That was great. Thank you very much, Dr. Roach. I wanted to just highlight one thing you pointed out. So one of the things we've talked about a lot on our task force calls is how all of vascular surgery is local, and everybody's experience is very, very different. Ours is that of a tertiary quaternary hospital that serves a quarter of the U.S. landmass, not the population, of course. Huge referral area, and we have no vascular surgery on site. And we haven't really developed there's nothing wrong with the people, but there is not a formalization or a great conduit to get to vascular surgery. It's doable, but and so our local resources are interventional radiology and actually interventional cardiology. We have access to the trauma center where we can transfer patients without problem, but there's a bit of a delay sometimes. And that just speaks to the variable experiences. People who are in a children's hospital within an adult hospital oftentimes have better access, more immediate access to vascular surgeons. So I think it really colors our experiences. I just want to highlight Dr. Stanley's comment about, back to our previous question about progression of clot in that infant or toddler. Should there be progression of clot, even if we don't have the Fogarty catheter that's appropriate size? Aspiration of clot with a fine catheter may be an appropriate aspiration thrombectomy and irrigation appropriate approach. Let me pause in the end of this first section to see if anybody has questions for Dr. Roach or additional comments about anticoagulation and workup. All right, Dr. Williams, but may I turn it over to you for the next parts?
Yes. Thank you, David. And that was a great discussion. And Gavin, I already learned a lot from what you had to say. So thanks for being here. And I love the algorithm or guideline on what to do. So the next case is a good case. It may be a far-fetched, but it's really the point of what we want to talk about. But this is a 10-year-old with perforated appendicitis who has had 5 days of nausea, emesis, and poor PO intake, and undergoes a laparoscopic appendectomy. Next slide, or click the button. Yep. So 6 hours post-op, develops intense abdominal pain, markedly out of proportion to abdominal exam. You get a CT scan because you're very worried, not the normal post-operative course for our APPs, and the CT demonstrates a superior mesenteric artery occlusion. Next. So what would we do next in this case? Erica, do you want to start us off?
Sure. Well, obviously something needs to be done because the risk of bowel ischemia is immense, and SMA thrombosis can be a life-threatening condition. So this patient certainly needs an intervention, and I would agree that nowadays you can do in lieu of an open thrombectomy, you can do a endovascular approach with the suction thrombectomy. I personally haven't done any, and I know our IR guys at Le Bonheur are great in this area. So I'm sure that would be, obviously first start anticoagulation and then figure out what approach you're going to use for mechanical removal of this thrombus.
Is there anybody that does have experience with the suction-guided thrombectomy?
I use it in adults, but I had one case when I was at a clinic. The pediatric cardiologists and cardiac surgeons called me when I was on call, and they had a child who had thrombosed their aorta from the arch down. Everything was out, and so it was a bit of a conundrum. But basically took a 5 French catheter, I think it was a glide catheter, and that basically was the size of the aorta, and just put a syringe on it and suctioned it and ran it back and forth, suctioning it, and finally was able to open up the origins of the celiac and one of the renals, and was able to get blood flowing back to the legs, and anticoagulated, closed up and anticoagulated, and the child survives. So it's again, less is more in these babies. If you're able to just, the clot was in there, but this happens, it was apparent that they spasmed and didn't propagate clot like it would in an adult. So it was just very lucky, but yes, I think it is feasible. I don't think that these catheters and instruments are sized for these babies and children, though. It's just you have to sort of think around, think through the problem, and it's very individual, and they're very rare. That happened almost 10 years ago.
Hi, this is Dr. Babu from Vascular Surgery. Just want to tell you that now we do have commercially available catheters called, the various companies now, particularly Penumbra, Inari, etc., that we use for adults for, pulmonary embolectomy, etc. But they come in really different size catheters, and this can be now used for pediatric cases nowadays, like SMA thrombectomy and aortic thrombectomy. So they're really sophisticated and very, very nice. They have amazing sophistication in this now.
Hey, this is Amna Ali. I'm a vascular surgeon in Nevada. I just wanted to add to that. I believe Inari is only on the venous side available, but in terms of like aortic arterial thromboses, I have done Penumbra and the SMA only in adults or young adults. But there is a CAT RX size that the Penumbra has, which is specifically meant for coronary arteries. It's the smallest one. that's available, and it fits in tibials for adults. So that would be 2 to 3 millimeter size. So I don't know if anyone has any experience with that.
Oh, that's very nice to know. I didn't know that they made it for coronary arteries. That's very good. That can
Yeah,
then.
it needs it for coronary thromboses, and I've seen that actually in stent thromboses been perc thrombectomized. It's called a CAT RX. That's their smallest catheter. I believe it's like 2 millimeters or something.
So this is the beauty of conference like this. So very nice. So if you can go into coronary arteries, then obviously we can go to many small arteries in children, then particularly SMA. Thank you.
Great. So what if you don't have the equipment or the vessel is too small? This is a 6-year-old, so bigger than the 4-month-old, but certainly not adult size. If we were gonna do an open exploration, what would that look like? Erica, do you want to start?
So with an open exploration, you would essentially dissect out the SMA, not at its origin, but where it branches out. And while the books do talk about a transverse arteriotomy, I tend to prefer a longitudinal so that you can individually thrombectomize the small branches. And a 10-year-old, you could certainly with a number 2 provoked catheter. And then I would vein patch, or in an adult, if there's no bowel ischemia, a bovine pericardium patch the SMA, so that you have a longitudinal arteriotomy that gives you access to all the small branches as the SMA divides into the branches of the bowel. So that's one approach. And then as we've talked about prior, we certainly in adults do use a thrombectomy, the CAT, for mechanical thrombectomy. So this would be a groin approach, access the SMA, or from the arm if there's the angle between the aorta and the SMA is steep, then you do a mechanical suction thrombectomy of the artery. I don't think lysis works very well because that prolongs the ischemia time, and I would be very nervous about leaving a catheter in there for 24 hours. If mechanical didn't work percutaneously, then I would go to the operating room.
All right, awesome. And then what would we do post-operatively? Would anybody anticoagulate post-operatively?
Sorry, I just wanted to add one thing to what Dr. Mitchell said, is that I also like to do a longitudinal arteriotomy, because when you patch it, you can stick your patch and do an angiogram to make sure that you got clot clearance of everything. If there's any doubt, or if your signals aren't great, if they've got a lot of vasospasm, which young people tend to get a lot of that. So, I mean, I'm sure all of us do this, but I kind of listen for mesenteric signals all along the bowel and examine it, and listen to Doppler signals everywhere. And if they're not great, you can stick your patch and do an angiogram and even give papaverin that way. And that can be a nice little adjunct. And if you have a patch, then you don't have to worry about narrowing it after you stick it.
Would you also use a bovine patch, or would anybody use a saphenous vein or a vein harvested from somewhere in the abdomen?
I think bovine patch has worked so well. I don't think we need to really go on looking for another vein. It really stood the test of time.
And is there any concern when you patch it about growth of the vessel over time, since we're talking about a child? Is there anything special that you want to do to make sure that it will grow with the kid?
I would preferentially use a vein patch in the child.
I'm going to interject with a couple of chat comments. Dr. Coleman says, be careful with vein in the abdomen. It dilates in children, even patches. And Dr. Chong had a question. Would anybody give systemic lytics in these catastrophic thrombosis cases prior to endovascular procedure if feasible?
Anybody systemic lytics?
I think I've done systemic lytics in adults, but I think that I agree with Dr. Mitchell that with SMA thrombosis, it's not a leg, and you don't really have the luxury of time. And if you're already taking them to the OR because they've gotten worse, like their serial lactates or their abdominal exams have worsened, then I'd be a little bit wary to do that, because I wouldn't want to make it worse. The other thing is with really small kids and small vessels, this leaving a lysis catheter there. I mean, the lysis catheter that we have standard is like a Craig McNamara and stuff. Those are pretty big catheters for small vessels. And the vessel, I'm sure there's people have had occasional experiences with this. If you leave a Craig McNamara in an adult and you don't heparinize the side sheath, that will clot off. And so I don't know if I want to do that to a child in their SMA, and form a long clot along a lysis catheter that's a big size, a French size in a small vessel.
Gavin, is there anything about pediatric biology where TPA would act differently than in an adult?
No, not unless you're thinking about like really small babies. But in most children and adolescents, it would essentially be the same. We institutionally don't favor systemic thrombolysis, except as a second or third line therapy if we feel like doing either catheter-directed thrombolysis isn't feasible or surgery is not feasible for some reason. But the literature that's out there, albeit it's not voluminous, but the literature out there would just suggest that the bleeding risks of systemic lytics are quite high, and overall the efficacy is not as good as doing either something directly surgical or something catheter-directed. So it's an option, but it's not a great option.
Yep. Comment from UT Houston about using systemic lytics, sort of locally directed in VA ECMO catheter thrombosis, getting into the aorta. Regan, can I suggest, do you want to, my next couple of slides I put in here, I think we've covered a lot of them. Should we move on to the aortic trauma one?
I think so. Don has a question.
Yeah, thanks, Regan. I wanted to make one comment around thrombolysis because I agree with all of the sentiment that's been expressed, but I do think there are a couple scenarios, especially in really young children, where systemic thrombolysis may be helpful. And I can think of cases of arteritis with associated thrombosis that's extensive and fairly disseminated in the small vessels, where both arms and both legs, for example, may have ischemia related to in situ thrombus. And in those cases, I do think there's some data to support the use of systemic thrombolysis. The other time where I think I've seen it used, even though it may not be first line, is when patients aren't at a site where catheter-directed or interventional techniques can be offered, and there's going to be some delay in transport, in which case I have seen patients managed with kind of the initiation of a lower dose of TPA systemically to facilitate transfer to higher level care when ischemia is really in question and the patient can't get what they need in that moment. So I do think there's a place for it, especially in the younger kids. And I don't know that it's every child that an interventionalist is willing to cannulate for catheter-directed thrombolysis. And so, again, I think it's super important when you're talking about an SMA thrombus in a 10-year-old versus a teenager. That's super different than an SMA thrombosis in a 2-year-old or a 6-week-old. And that approach is invariably going to be different, again, based on resources. But I think everything that's been suggested in that kind of hierarchical set of considerations, I fully agree with.
And I agree with everything you just said, Dr. Coleman. Absolutely.
Yeah, Don, I appreciate your perspective. And I guess, to sort of circle back to the interventional side, we've used penumbra very occasionally in these mesenteric issues, but, it's fraught with, further arterial injury. It's fraught with trying to use, especially for the SMA, a Tor guide catheter sheath, and in a 10-year-old with a, I think you need like a 5.5 or 6 French sheath to deliver the penumbra device. I don't think that I would attempt that. Would you?
I feel that there's lots of data around the first line use of endovascular therapy in adults. And I just don't know that the same data is there for children because this is such a really, really unusual, uncommon problem. And it's not atherosclerotic related disease that we often will see in situ thrombus in our adults. So it's a totally different perspective. I agree with the sentiment that I think was expressed by Dr. Mitchell and others just around an open exploration and treatment. And I have to be honest, even in my adult patients, I'm pretty conservative, favoring open procedures for acute mesenteric ischemia. I feel a lot more control over that situation because you have direct access to the vessels. I like the patch. The only thing I would do different personally is not use a vein patch because it will dilate over time in these kids, and I'd have no problem taking a little piece of hypogastric artery and using that for my patch conduit. So I personally have no experience with this coronary penumbra, though. So it certainly adds to the armamentarium, and maybe that's a really great thing, especially as our technology evolves for some of our more complex kids. But I personally have a low threshold to do this just open based on how the case was described.
I'd say having used the coronary penumbra as well, I don't think I would use it in this case. I appreciate your comments. Thank you.
Thanks, everybody. Benjamin.
Hi, this is Ben Lane from Columbus, Ohio. What's your go-to choice for catheter-directed thrombolysis? Just because, like we talked about before, the crag is pretty big, and these, even a 4 French sheath in a very less than a year-old child is not. It's going to be occlusive in there a lot of times, and so I don't know what when you guys. I feel like a lot of people were saying that they prefer to do a catheter-directed thrombolysis, but I don't know what device you guys are using for that.
There's one comment that says infusion wire.
So infusion wires are not. Last time I spoke with Medtronic, they were no longer making that infusion wire.
Oh. Anybody else have any suggestions for Ben? Me as a pediatric surgeon, I can't help with this one.
I think that's. I mean, I think the biggest challenge, at least from
am.
what I'm seeing, is that a lot of times we get these patients and they're too young and they're not big
Yeah.
enough to get.
I totally
And
agree with that. I totally agree with you. I think that if they are, and I've personally never done this, but just thinking through it, I think the smallest Craig that I've ever seen is a 4 French. The CAT RX penumbra is a 5 French device. The catheter itself is smaller and can get into 2 to 3 millimeter vessels, is what its IFU is. But the actual size is 5. The Craig McNamara's come in 4s and 5s. So I think that that's just kind of something that, your clinical and surgical judgment you have to use on the size of the child, the size of the vessel, the amount of thrombus. But I agree with penumbra. I have penumbra SMAs in young adults and older adults, but you have to be ready and willing to chase the clot because sometimes it will push it. And if you're not willing to do that, if it's just, if you have a patient that can tolerate open thrombectomy, I think that would probably be my preference. But it's good to know that it's there. One case I did about a year ago was like a 17-year-old girl who had a PFO and had arterial and venous simultaneous thrombosis. So she had thrombus in her SMA, she had thrombus in her celiac, she had thrombus, and she had a PE. So I did it all perc because there was just so much going on. I used a penumbra and I suctioned out her celiac and SMA, and then I used an Inari and went after the PE. And then, because she had a bunch of cardiac issues, the aim was to get her off the table, within like 2 hours or something. And so I think that person's vessels were not very small, obviously. They're basically they're almost an adult sized person. But those are the sizes that I'm aware of. And if anyone knows any different, please feel free to pitch in.
Well, I hope you also close the PFO on your way out.
I'm not qualified to do so, but our cardiologist did. And sorry, I have a sore throat.
Yeah.
So I'm mumbling, yeah.
Sorry, let me be the timekeeper. Let's move on to our third case, which is an aorta case. So Mary, you can go on to this. Is I think case 3.
Perfect.
There you go. Thank you.
Yep. So this is a 15-year-old who's involved in a high-speed motor vehicle collision. CT demonstrated an aortic dissection. So what's the current recommendation for aortic dissection in a 15-year-old? And let's say they have a grade 2 spleen and a really small IPH in the head. Just, make it interesting.
So the current guidelines for blunt thoracic aortic injury is to treat a grade 3 or 4 injury, or a patient who has a traumatic acute aortic coarctation, or so presents with malperfusion. While grade 2 was traditionally touted as an indication for TVAR, that is going away. So a grade 3 and 4 for a 15-year-old would be essentially standard of care.
Can you go to the next slide, Mary, just to address Dr. Mitchell's classifications there? Dr. Williams had a slide there.
Yeah. So this just shows the grades. And interesting about the grade 2 changing, because the 2010 guidelines did have that in there. So what is the treatment now for grade 2, Erica, and why did they change it?
So as Mary knows, I'm sitting on the task force right now for changing the criteria. And I think we've noted that there's kind of a mosaic between grade 1 and grade 2, and there's really no cutoff in essence. And observation alone has been successful. And these grade 2 injuries do heal without endovascular therapy. And so now the paradigm has shifted to grade 3s and 4s. This grading system, however, does not include patients with malperfusion syndrome, and that's patients with severe aortic narrowing at the zone of injury.
Okay. Next slide. I think this is just some information. So, thoracic aortic injuries, super rare in children. There was a recent review in the NTDB, the National Trauma Database, that just looked at the treatment and what people were doing. And so most of these injuries were treated non-operatively. They're about 30% with TVAR and 6% that were open. What this review showed was just that TVAR is safe in children, and it can be associated with a lower mortality than open repair or non-operative management. And I think that goes along with what Erica said. The one thing that has come up when we talk about this is what size stents to use and what the smallest one was. And so I have, over the last year of working with these wonderful vascular surgeons, figured that you can get down to a 16 millimeter stent. But does anybody think there is something smaller, or what would you recommend for stent placement and endovascular repair of these injuries? This is a 15-year-old, but what if you had a 5-year-old?
So for endovascular repair, there's devices from Gore and Cook, and the management is different than for dissections and for aortic disease, aneurysmal disease, in the sense that the stents are much shorter. So we use a 10 centimeters, the shortest one that we use, and that markedly decreases the risk of spinal cord ischemia, because you're not covering the distal 1/3 of the descending thoracic aorta. And I don't have any experience with a 5-year-old. So obviously that becomes a different issue, and there aren't any endovascular devices small enough, and probably it's inappropriate to put a stent in a 5-year-old.
So would you recommend open repair or non-operative management? Let's say it's a grade 3.
If it's with a grade 3 pseudoaneurysm and intramural hematoma, I would recommend an open operation.
It's one of the instances where a stent graft would be a temporizing maneuver to get the patient through what is probably a multi-injury situation. I mean, the energy required to break the aorta of a 5-year-old has probably broken a lot of other things. So putting in a stent graft of suitable size, understanding at some later point that's going to be repaired open, maybe a safer maneuver. But I have no experience with this.
So the data in adults is showing that you can delay injury of a grade 3 blunt thoracic aortic injury to greater than 24, greater than 36 hours. Although that data is a little bit skewed because it doesn't include the patients who die immediately. So if you survive long enough to survive a couple of days, then you're going to survive a few more days. And so that way you can manage the other injuries if you have the concomitant liver injury, splenic injury, that sort of thing. So, I mean, obviously it poses a very different challenge in a child. And I would agree that there'd be significant concomitant injuries in a child, aortic injury.
You have a comment or question, Nicole?
Yeah, so I mean, I think what Erica said is well taken, and I agree. And we've really shifted our practice in adults and in our sort of teenage population, adolescents, and all that for sort of delayed treatment of these type 3s. But if you are pushed in this situation, to be very honest with you, I think that these are really, and I don't know who made the comment, but these patients and the issue with their morbidity and mortality has a lot to do with their other associated injuries. And I think if you're pushed to doing it, I would still consider treating this endovascular. We've got, dedicated aortic stents that, go down to, I think, 16 millimeters, as was mentioned here, but we've got other covered stents that we could use. And I would consider doing that. I actually did that in a patient 10, 12 years ago who was undergoing a resection for testicular cancer, was very young and had a very small aorta and ended up rupturing in the PACU. And temporizing with those stents, I think, can be helpful. I think the bigger question, though, and what Erica brings up, though, is, they're certainly going to outgrow these stents. So if you were going to do that, if you were pushed to doing that, I think the idea would be to temporize beyond that, 48, 72-hour window, but certainly the patient would at some point need an open repair.
I'd just like to piggyback off of that. I actually think endo is great for stabilizing trauma patients in general, and I agree with what was just said. The aortic stent grafts dedicated go down to 16 in adults, with small aortas or teenagers with trauma that I've done before. An 8L VBX can be dilated up to 13 millimeters size, and we do that all the time. The distal abdominal aorta, for instance, when you're doing like a CRAB procedure or something like that. Obviously, the question comes up as to where in the thoracic aorta it is. If you're at a point where there's a lot of curvature, you have to use an aortic stent because otherwise you'll get a lot of bird beaking with your graft. But there is an option available for 13 millimeters, and you can get 8 to 13 on a covered stent, as was mentioned before, in terms of just using a covered stent, and then 16 above for dedicated aortic stents, which are on the IFU or basically the kosher way of using these stents.
Can I ask a naive question from pediatric surgery? So if you place a stent to temporize, let's say trauma or otherwise you don't want to do an open repair, and you would go back in 2 weeks or whatever number of weeks later, or months or years later, can you remove that stent, or is it engrafted and you have to replace the entire segment that is stented?
I can answer that. Usually what I'll do is I'll have one of my partners do that part of the operation. So I just do the temporizing procedures.
My man.
Good answer. Good answer.
The stents come out pretty easily, especially if you're doing it 2 weeks later. It's usually not an issue. But the downside to it is you can cause some further injury to the aorta, and you might need to repair sort of a larger or longer segment of aorta.
Dawn, did you have a comment?
Is this the right time to give Dr. Mitchell time to look over her slides?
Yeah, I was just gonna let Dawn had her hand up, and then we can move over to Erica.
Oh, no, just a quick comment that I do think there's a role for endovascular treatment and stabilization of multi-trauma patients, for sure. I'd also just propose that in the thoracic aortic space, there is evolving technology that supports covered stenting for thoracic coarctation patients, and even some stents that can be further dilated in time. So I do think this is an area that's actively evolving. And while we might not say there's an on-label stent graft for children who need a size smaller than 16 millimeters, I do think we can be thoughtful with our use of other covered stents. And again, I think we can borrow from the thoracic aortic coarctation practice if that's prudent. So I think there's more coming down the pipeline.
Excellent. All right, if you want to go forward, Mary. We're now going to turn it over to Erica with some cases based on her experience with pediatric vascular surgery at my center in Memphis. Thanks,
Yeah.
Erica.
It's our experience, Reagan.
It is our experience, but you know.
So I don't know if any of you have seen the movie My Teacher, My Octopus. This is how I liken this. I've learned more from my trauma experience than I think I have in the last 3 years than any other realm of vascular surgery. So I've been there about 44 months, and in that period of time, we have the vascular surgical service has been consulted to see 179 pediatric patients, and that includes both the trauma hospital I'm working at, which is generally the teenagers, and then of course most of the younger adults are transferred to Le Bonheur. And in that time period, the age, as you can see, the majority of the patients that we've been consulted on are 12 to 18-year-olds, with the majority of them being male. We broke them down into the conditions that we're being consulted on, and 2.5% had congenital or genetic conditions, of which half of these patients had cardiac in origin conditions, and then 7% acquired conditions. And as you can see, we treat a lot of traumatic vascular injuries in Memphis. Next slide, please, Mary. And so when you look at the traumatic vascular injuries, I broke them down into iatrogenic, and then I separated the catheter-related versus the ECMO-related. And the only reason I did that is I think the ECMO-related devices are much larger in diameter and really are more occlusive. And sometimes the catheters are maybe too large for this patient population because that space just hasn't evolved yet for the smaller size diameters that are needed. And then 3 surgical, and that includes St. Jude's. And then as you can see, the traumatic injuries, the majority of them are penetrating in the city of Memphis. And just these pictures alone, that first one on the left, that's a 3-year-old with a gunshot wound to the iliac artery. And then that hand one is an iatrogenic injury from a radial A line that thrombosed the radial artery, subsequently thrombosed the palmar arch. And we had the plastic surgeons help us get down to the palmar arch for mechanical thrombectomy. And then we do the blunt injuries are more orthopedic related. They have concomitant vascular and orthopedic injuries. And then of course, you can see the dreaded iliac artery on the stick on that right side. Next slide, please. And so what we found is that in retrospect, the patients that have the catheter-related limb ischemia have all been very young, and our therapeutic treatment essentially has been anticoagulation alone. Next slide, please. And that, of course, is driven multidisciplinary with our hematologists, as well as, of course, all of our patients are managed by the pediatric pediatric trauma surgical service. And so Lovenox is typically used in our hospital, as Gavin alluded to, and he gave us the physiologic reason for. And then they get serial duplex. And as you spoke about, Gavin, while we haven't stated your approach, it seems like in hindsight that's kind of what we've done. But I like the way that you've outlined it nicely for a systematic approach. Next slide, please. And then the patients that have had ECMO-related limb ischemia, every single one of these patients have required some kind of vascular surgical intervention. Next slide. And that's differed from arterial reconstruction to fascial prolonged leg ischemia, or sadly, in some cases, amputation. Next slide, please. And so I would say that vascular surgeons are playing more of a critical role in the management of pediatric vascular trauma. And it just speaks to the changes in training paradigm in general surgery and how vascular cases have essentially been taken away from general surgeons as well with the advent of the 0 and 5 programs. Next slide, please. And then when you look at the surgical interventions that we performed, 70% were open, 24 did require endovascular approach. And I'd say these are more of the the torso, so abdomen, chest, and the junctional zones. That would be subclavian and iliac arteries. We have not used endovascular approaches for the periphery. And then the arterial reconstructions is stented 6 aortas, 5 of them were thoracic aorta, and then a lot of bypasses, upper and lower extremity, patch angioplasty for the smaller vessels, and then primary repairs, the smallest child being 3 months. And then we've used native conduit for all of our reconstructions. And the techniques, as Dawn can describe, differ a little bit in the sense that we use a very large beveled spatulation technique for end-to-end anastomoses, as well as interrupted proline sutures, so that you consider the growth of the patient in the future when you are doing the vascular reconstructions. Next slide, please. In my other talk, I had a lot more pictures, but that's essentially our experience. And as Reagan can talk about, the management of these patients is solely driven by the pediatric surgical services and hematology in the sense of anticoagulation alone.
Oh, thanks, Erica. I think David really talked about this early on, but just how important the collaboration amongst the service lines is in taking care of these patients, because all of the things that we've talked about tonight are extremely rare, and nobody has a ton of experience with what to do in a 2-year-old versus a 5-year-old versus a 10-year-old. And then again, he noted that vascular surgery is all local, and I think that we probably could all talk about how we do things, and it's all slightly different. We've been really lucky in Memphis to really collaborate closely with our adult vascular surgeons. They're not in our system, but they're across the street, so they come over fairly easily. And the pediatric surgery service really helps work up the patient, helps manage the patient, collaborates with the other services. We have an excellent hematology service at St. Jude that comes over, but it's teamwork. And I really liked how Gavin had the huddle, the emergency huddle, because I think it is everybody getting together to figure out how to best take care of and manage these patients in real time. These aren't things that can wait till the next day or the next month, but it does take a team approach if we want to optimize how we manage these kids. We have about 10 or 15 minutes left. So are there any comments on traumatic arterial thrombosis, or really just this concept of collaboration and how we best manage pediatric vascular surgical patients?
Hi, this is Dr. Babu from New York. I just want to ask Dr. Mitchell, what is the native conduit you mentioned in these very small children? Can you elaborate on that? What do you use? I thought saphenous vein is too small in these kids.
I have been shocked how big the saphenous vein is. And
is that right?
The vein is, I mean, even in a 6-month-old or a 3-year-old, the vein can be 4 millimeters. I mean, well, maybe not a 6 month, but the 6 months certainly can be 2.5 millimeters. But that's something that I have learned, and I always thought the veins were small, but they aren't.
Oh, thank you. That's interesting to know. We were all under the impression that they're too small to use, so that's good.
There's a question in the chat about antiplatelet regimens in children post-open versus endovascular intervention. Are people using aspirin or Plavix, and what dose? I would add for how long. That's certainly something that comes up in our patients a lot. So does anybody have a consistent way that they manage these patients post-operatively, and is it different for open versus endovascular interventions?
Well, we routinely prescribe aspirin, so 81 milligrams, after a traumatic arterial injury. Sometimes we use what we call voodoo heparin postoperatively in 48 hours, or chicken heparin. But we do send patients home on aspirin, and I'd say it seems like patients stay on it for about a month, and then it kind of drops off. So when we see patients a year later, most of them are not on aspirin anymore.
Gavin, is there any data or recommendations that you've found on this one?
So I will confess that pediatric hematologists never prescribe aspirin for anything. We don't believe in it. No. Mostly aspirin is used, of course, in like congenital heart disease, Kawasaki disease, adults with MI and stroke. So in all honesty, I never prescribe it for anyone, but I've actually been looking into this lately because David had asked me to contribute a little bit to some data that he's looking at for management of patients after vascular repair when coming off like ECMO, for example. So what I have found in so far is that really there's like no literature in pediatrics for what to do with antiplatelet agents. All the data we have is from adults, and in the adult world, arterial disease is much different. It's mostly atherosclerotic. The types of clots that adults get are these so-called white clots, which are mostly platelets and fibrin, which is not maybe the same as what children are getting. So there's so much that's not known about the best way to manage children after these vascular procedures. So I don't think there's a standard. I think, as you've already said, most people use aspirin and or maybe Plavix for some amount of time. We don't know how long is the best amount of time. And I'm thankful that no one expects me to be the prescriber for
that. Thank you for being so honest. I do think that I have found that most patients get aspirin after repair, and some of that is just like hoping that it doesn't clot. But I agree with Erica in that most of our patients don't stay on it for very long. It's hard to get good compliance, and I don't think we really know how long they should be on it. Is anybody else the dreaded Rye syndrome? Does that really happen that much? And isn't that just if they're less than 5? Anybody? No, I'm probably the only Pete's person.
So our cardiologists will occasionally put these kids under 5 years old on aspirin, and we thought that's what we said too. We said, are they gonna, is a concern for Rye syndrome? But then they're the ones a lot of times put them on it for whatever period of time, and they manage it from our center or from our nationwide children's. So I've seen them use it multiple times.
I'll also just add that I can at least speak to an institutional experience that encompassed probably more than 400 patients that underwent open surgical interventions of some sort that were treated with aspirin, ranging a pretty broad range. I have never, nor have we documented in that series at the University of Michigan, come across Rye syndrome ever. And the only aspirin-related complication I can speak to was a teenager who developed peptic ulcer disease in blood. So we talk about Rye syndrome, and it's on all our exams, and I've never seen it, nor have I had anybody reach out saying that their aspirin needed to be stopped for it. It's never come up, clinically speaking.
Yeah, I think the general rule of thumb in pediatrics is if you need aspirin for some reason, then just do it.
Yeah.
But
good
like
point. Good point.
Not for a random fever, maybe.
I'd like to comment on 2 things related to what Dawn said. So when you do a bypass or you reimplant a vessel or you mobilize it and do an anastomosis, the problem in children there's not much room for platelet aggregation when there's no endothelial cells that you've lost. So whatever the time it takes to re-endothelialize those vessels, we felt comfortable, as Dawn mentioned, to have children on aspirin. Frequently, when we do almost a microanastomosis in the abdomen and truncal reconstruction, we'll use heparin. It's been a big operation. We've mobilized a lot of things. We don't want to leave the child on heparin postoperatively, but we'll have anesthesia administers aspirin down the nasogastric tube. And we've not seen bleeding problems with that. I'm sure if we kept the child on heparin for a while after a big abdominal procedure, we probably would. And one other comment, if we've got a few seconds, related to mesenteric arterial thromboses. I mean, if you've had the delay and you have pretty profound ischemia of the small bowel or the colon, there are a lot of vasoactive means that perpetuate that occlusive disease. Everything clamps down, and not in children. I've used it once in a child with mesenteric vascular problem, but in adults, the old history used to be put a catheter in and give infusions of epaverin for a while. You don't need to do that. You can get a complete block of intestinal motility with glucagon. And it stops all gut motility. Radiologists use it all the time to get hypotonic duodenography and things. And I have no idea what the real adult is, or pediatric dose is. In adults, it's around 4 milligrams for an average 70-kilogram man or woman over a period of an hour. It's an infusion. It's very vasoactive. But if you have a piece of bowel that looks like it's profoundly ischemic, after you've done a thrombectomy or a lysis or something, and you happen to have done coleotomy, I don't think it's unreasonable to use something that stops gut motility. The muscularis mucosa is like a precapillary sphincter. You stop gut motility, 70, 80, 90% of the blood flow is in the villi. It's not in the, in the muscularis mucosa can stop that pretty cold if it goes in contraction. It's a random thought like everything else we've talked about, or a lot of things we've talked about. There are no prospective data, but in a desperately ill child, I don't think it's an unreasonable thing to consider.
Thank you for your comments. So we just have about 5 minutes left. These are just a few of our future directions for our collaboration with the SVS and APSA, which is looking at technology. What are our goals? What are our needs? I mean, we mentioned that a lot today of getting catheters and equipment to the right size. We've talked a lot about medications and anticoagulation, and I do think we need to come together to study this and understand exactly how we should be monitoring the patients and treating them pre and post-operatively, and what medication works best. We've talked a lot about a registry. There is a traumatic vascular injury registry that Natalie Drucker and UT Houston are going to be starting, called Prove It Peds. So Prove It was the adult version, and Peds is, of course, traumatic vascular injuries in Peds. I think that's going to help from the trauma side. I'm a pediatric trauma surgeon, so that's the space that I live in. But, if we brought up today in some of the other webinars, there's multiple other diagnoses in pediatric vascular surgery that we need to come together and collect some data so we can better understand how to treat these patients. And we're only going to figure it out through collaboration. So we have really enjoyed this task force. We hope to continue it and to grow it and to really develop some guidelines and recommendations so that we can optimize the treatment of these patients. And then there's a couple comments. One was, how are you managing access pseudoaneurysms in infants? Do you watch and wait, or do you inject thrombin? And then Justin Sabrino, pediatric surgery, said that he has a PEDS ID guy sitting next to him that says that influenza is a risk factor for Rye syndrome. And so don't give aspirin to someone that has influenza, I think.
I think we've arrived, Regan. If we have an infectious disease person listening to this webinar, it's amazing. Thank you.
And then Don or John, do you have any closing comments to add?
No, I think it was an outstanding symposium. I learned a lot, so it was great. Thanks all to the speakers.
Huge thanks to everybody. Regan and David, nicely put together. And I just want to say thank you to Erica and Gavin for bringing your expertise. Jim Stanley, thrilled to see you here. And this actually has been such a nice crowd. So I'm hopeful we can continue this again quarterly. And Mary and Reva hold us together like glue, and will keep us together moving forward. They'll reach out with some follow-up after the webinar, simply seeking your guidance on themes and discussions that should be prioritized. for upcoming events. I'm confident we'll have some educational content on the program at VAM this year, so please stay tuned to our vascular surgeons in the group. And I just want to say thanks to everybody who cares to think about these kids, treat them. It's hard, and is committed to learning as much as we can collectively about how to advance their care forward. So this has been a really exciting evening, and just well done to everybody. Again, thanks so much.
Thank you.
Thank you, everybody.
Thanks, everybody, guys. Good night.